Welcome, everyone. We are so glad you're here with us this afternoon. And we are excited to kick off the first of a three-part training on collaborative care model. And we have with us Dr. Verna Little. And we're so excited to have Verna here. Before I give her a formal introduction, I just want to remind everyone we are recording today's training. And we will be using this training as a training resource for practices that are interested in the collaborative care model. We will be posting this to the collaborative care model webpage. And this is a webpage that has been created specifically for this grant. So really excited that we're going to have this training resource. I know sometimes it's challenging to get all of your team to the training. So know that this will be a training resource for you. They'll be able to watch this in chunks as their time allows. So with that, it is my honor and pleasure to introduce Dr. Verna Little. Verna is the co-founder of Concert Health and the co-founder of Zero Overdose. Verna is an internationally known speaker for her work in integrating primary care and behavioral health, developing sustainable integrated delivery systems, and suicide prevention. Dr. Little is an expert in the collaborative care model, and she provides technical assistance to organizations and states around the country, integrating primary care and behavioral health. She was just telling us she was doing a training this morning for the state of New York, and we know that she has been integral in providing training and support to them. They are also a grant recipient of the SAMHSA grant for the CoCM model. Verna has been recognized with awards from the Society for Social Work Leaders in Healthcare, National Association of Social Workers, Community Health Center Network of New York. And we know this past year, Verna was the recipient of the award at the CFHA conference for all that she's doing in the CoCM realm. And so I have to say, when I think of Verna, we have heard her referred to as the CoCM queen. And so we know that Verna is absolutely the go-to person in the entire country on CoCM. And we're so grateful that she is here today and providing us with this training. We want this to be interactive, so please feel free to bring yourself off mute, ask questions in the chat as we go along this afternoon. And with that, I'm going to turn it over to Verna, and she's going to lead us today.
Great, thank you. And someone used to said to me a while back, "Oh, the mother of collaborative care." And then recently, someone said the grandmother of collaborative care, and I was like, "Oh no!" So I was really glad to hear you. I use one of those. I was like, "Oh heavens!"
I like the queen.
I don't even know if I need any of it, but I prefer that to the, not that I don't love being a grandmother, because I totally do, but I was like, wow. So, well, thank you. I'm really glad to be here. I definitely want this to be interactive and, take yourself off mute. And I am so not offended by like jumping in, cut me off. And also I do watch the chat while I'm going along. So if you're feeling shy, you have background noise, like my dog just decided to have an opinion a moment ago, then feel free to, just use the chat. But what I really want to try to do today is to really talk about collaborative care, sort of really like, what do you need to know? The absolute foundation. We're going to debunk some myths. We're going to have some conversations. What do you need to really understand the model and to move forward? So we're going to take time for discussion. We're going to really do a deep dive. So a couple of things that you really need to know to frame, collaborative care is really a primary care initiative. And I can't tell you how many organizations come, and it's often, the behavioral health leaders that are sort of tasked. It does make it really hard. without the primary care engagement and involvement. And really, it's a primary care medical director leadership initiative. They have to be involved from the get-go. It makes life much easier. And oftentimes, I can't tell you how many organizations I've gone to and primary care didn't even know it was a primary care initiative. And so really sealing that from the get-go. And that it is a population health approach. You have to go into implementing collaborative care with a population health approach. Very different than counseling or therapy. We're going to identify people, we're going to provide therapy, right? We don't think about our population of diabetics that way, right? Oh, we're going to provide some diabetes education. We think about them as a population. Some need diabetes education, some need nutrition, some need insulin, some need all, right? So very much the same way, really has to be a population health approach. We already have behavioral health. I can't tell you how often I hear this, particularly with FQHC partners, and I love that. Most of the time, that's actually all of the time, that's actually a beautiful match. And we're going to talk a little bit about how to think it through. But this isn't an either or. It doesn't mean, well, we already have behavioral health, we don't need this, right? It's kind of like saying, well, we already treat asthmatics, so we don't need to do anything with diabetes, right? And so we really want to make sure. And probably the most important thing is that it's really important to understand the model and have a really good, deep understanding of the model. And so what is collaborative care? So tonight, when you're at your dinner table, right, and somebody says, what'd you do with your afternoon? You can tell them, you know what, I did a really deep dive into collaborative care. And collaborative care is an evidence-based model to identify and treat. And I really want to have you pay attention to that word treat, with measurement-based behavioral health conditions in health settings. And so that's really where our focus is. It used to be, we used to just talk about particular diagnoses, but now if we can measure, then we can actually fold it into collaborative care and all types of health settings, pediatric, geriatric, women's health, you know, OBGYN, cardiology. Actually have a podiatrist in Arizona that loves collaborative care. Actually has been a very active collaborative care participant, GI, particularly with all the new research and understanding about how your gut and your mental health are really connected. So really understanding what collaborative care is. I always take us right back to the roots very, very intentionally so that people sort of know where it came from. You will hear impact, project impact, right? Improving mood by promoting access to collaborative treatment. That's where we started. The late 90s, early 2000s, big research trial, 1,800 adults, 400 primary care providers. It was then seniors and depression, and it has since morphed since then. But I think it's really important to know that this started as a research evidence-based trial now to over 20 years ago. And so collaborative care, when I did my first collaborative care implementation, it was literally it was just under 20 years ago now. And so collaborative care is not new. It has been around, and now actually we looked the other day and there's a new thing about research, but for those of you who like research, there are actually over 100 randomized control trials that support the efficacy of collaborative care. And there are lots that are not randomized. So I know I've myself put out a couple articles in the last year about the effectiveness for women's health populations or pediatric populations or rural populations that are not randomized control. So if any of you want information or literature on a particular population and you can't find it, or you need it, reach out to me and let me know. And I can tell you where to be able to find it. So one of the things that they found is, of course, that collaborative care is more effective than doing things as usual. So one of the practices in the original trial they went there and they said, oh, you have behavioral health here? Like, you can't be in this trial. And the medical director was like, whoa, hold the horses, wait a minute. Yeah, put us in, because I think we could actually do better than we're doing. And lo and behold, they actually got better outcomes. And so really doing something different, putting a system in place to care for a population of people with behavioral health conditions is really important. And I don't know, we shared it out, but if you don't have it, Kim could probably share it out, or Caitlin. There was a report this week that was put out around collaborative care and total cost, healthcare cost savings. Very, very important to really bring back. We know that it reduces utilization. We know that it helps chronic illnesses. I've seen it really have a huge impact on populations like cardiology and readmissions if I've had a cardiac event, pulmonary disease and emergency room utilization. So really making sure that actually or really knowing that those things, like I've seen those things in practice, reduce utilization, reduce ER, reduce. And so thank you, Caitlin, for sending that out. Seems like some people maybe hadn't had a chance to see that report. And it's actually like literally came out last week, I think, the end of last week. So when we think about reimbursement now, of course, Medicare, because there were dedicated CPT codes in 2017, we are actually up to 34 states now that have the Medicaid, the codes on the Medicaid fee schedule. There are a couple of folks who carved out Medicaid or FQHCs. Montana is the only state that carved out FQHCs, and you are the only state that carved out Medicaid for the fee schedule. Commercial plans, of course, all of the commercial plans. So I know some of you are FQs. The commercial plans auto added these codes into your contract, so you don't need to do anything. They're already there. So when you think about doing collaborative care, sometimes people say, well, we're only going to do it with this patient, or we're only going to do it with these patients. Do it across your entire payer mix. There's absolutely no reason at this point, even if you're not going to drop some claims and you want to just put them, it's across your payer mix. So really making sure you do that. It doesn't make sense to just do one population. And in fact, we know definitively from provider adoption that if you don't do it across your payer mix, providers don't refer at the same rates. Like we've seen that over and over again. Even if most of the patients are Medicaid and there's a smattering of commercial or Medicare, they don't adopt at the same rate as if you do it across your payer mix. So really just something to keep in mind as you're thinking about it. So one of the things that when CMS passed these codes in 2017, they literally said collaborative care was their gift to primary care, that passing these codes was their gift to primary care. And there's a couple of reasons that they say that. The first is that it's a monthly case rate. So what it does is it allows me to do whatever's needed over the course of the month. I'm not restricted to 45 or 30-minute sessions. I'm not restricted to a particular phone or video or in person, right? I can do whatever's needed over the course of a month. So really keeping that patient-centeredness. But that makes life way easier. Because these are primary care codes, we don't need any prior auths for mental health treatment. We don't go to, it doesn't go to a carve out. We don't have to credential with the plans, our clinicians that are going to be doing collaborative care, because the billing happens under the primary care providers. They're the only ones that can bill these codes. And so it doesn't matter if you hired me today, right? I'm a psychologist and a social worker. I am not licensed in your state. And you hired me today. I could actually start doing collaborative care today, right? And you could bill for me at the end of May, beginning of June. And so easy peasy, right? That's how it's meant to be. There is a broad care management description. CMS did that intentionally. So while the clinicians or the behavioral health care managers don't need to be licensed, they do need to be able to provide the treatment choices. But CMS was intentionally broad and said, we're not going to put a diagnosis list together here, because they knew that the diagnoses that we could measure outcomes for were going to increase over time. And they didn't want to have to keep adding. And so they didn't put ages in there. They did those things intentionally to really give us the ability to provide the kind of care and create the kind of access that we really need. And so CMS, it was really good that they were able to do those things, and to be able to think about that. So when we think about some of the myths, I think it's important to be myth busters right up from the get-go, so that we can just take some of them on, right away, and then we can move forward. So starting with some of the easiest ones, still a huge misconception out there. I did a talk the other day and somebody raised their hand. I literally was like 8 minutes in and they're like, I don't think we should really be encouraging medications, and there are people who don't need medications. And I said, well, yeah, of course, I agree. Like, I don't understand. And there was this big misconception that people needed to be on medications. Patients do not need to be on medications for collaborative care. In fact, the study that I just did with our women's health population and reducing anxiety, most of those women were not on medications. Most of the adolescents do fabulous in collaborative care with learning some different skills, right? Don't need medication. So that's big misconception. The other is that we need to pick a model, right? We have to pick collaborative care or PCBH or something. That's kind of like saying, well, we need to pick insulin or metformin, right? Sometimes one works, sometimes the other works. It's not about picking a model. It's about caring for the population. And so we're going to talk about what that looks like and think it through. Collaborative care is not therapy. And so one of the treatment choices that we're going to talk about in collaborative care is talk treatment, which is therapy. I use the same skills and the same tools and the same practices in collaborative care to care for my patients if I, was caring for them in a community mental health center. So therapy or talk treatment is actually one treatment choice in collaborative care. Collaborative care is a lower level of care. So collaborative care is a model of care, right? It's an evidence-based model of care. DBT is not a lower level of care than CBT. It's just a different evidence-based practice for a different population, right? And so collaborative care is the same thing. Collaborative care actually, and I will share next week a paper that's coming out that we did, that collaborative care actually is incredibly helpful for people at risk for suicide in reducing risk, because it is so high touch, it is so flexible, it is so patient-centered. And so sometimes we need to move people to different care. Sometimes we do need to move people to a higher level of care, like inpatient or a day treatment program or something that's way more specialized, right? But collaborative care doesn't necessarily or shouldn't be considered as a lower level of care. I often hear people doing collaborative care, well, we referred them out to a higher level of care. You just referred them to different care. So, and I think that helps the perception in your organization if you don't use terminology. Collaborative care is brief treatment. So I'm not really sure what brief treatment means, quite frankly. But what I do know is that people want to get better and we want to get them better. And I know that it takes, the average collaborative care episode is about 6 to 8 months. And so if we really focus in on symptoms, we can get people better in 6 to 8 months. We don't need to tell people it's brief treatment or think of collaborative care as brief treatment. We're just going to get people better and we're going to hone in and focus on their symptoms. So I think we do a big injustice when we describe collaborative care as a lower level brief treatment care to our providers, to our patients. Because then I think it doesn't actually help, and it's not actually really descriptive about what collaborative care is really meant to be or to do. So I'm going to stop there for a moment and just any questions, comments, thoughts about what we talked about to this point, or thoughts about, or any other myths you want to ask about or debunk.
Verna, I just have to say, thank you for talking about the myths. One of the things that I think happens, and we definitely hear in different health systems, is I think sometimes there's hesitancy about starting some of the integrated models because it could be competing with specialty mental health. I don't know if you could share your experiences. Do you hear the same thing? And any thoughts for us, as we don't just introduce CoCM in this project, but ultimately as we'll want to scale it across the state?
Yeah, I'm going to have you hold that thought. I actually have a little grid that I'm going to share, and maybe we talk through that a little bit to kind of
Sure.
think about it. I will say, though, oftentimes where I hear people, just to share this now, is a lot of times many of the people we care for have a history of really traumatic events. Like it's heartbreaking sometimes, or many times, to hear what people's experiences have been. And many times I'll hear, well, people with a history of trauma or those traumatic experiences need specialty mental health. And what I have found for many people is that it's really difficult to go and get treatment for some of the experiences you've had in your life. And it's really hard, and it's very often anxiety producing for people. And many times people go and don't stay in treatment. And what I have found is that those individuals, two things, do really well in collaborative care because we're very focused on symptoms. It's not your experiences, but what you're experiencing every day, your daily experiences. And that is incredibly helpful for people. And if we can reduce some of those daily experiences, someone is sleeping better, they're having less flashbacks, they have some coping, maybe some deep breathing that they can do if they start to feel hypervigilant, they get very empowered. And it's like, I do have a sense of control. I can actually have some change and some control. And with a successful collaborative care episode, they then, if they choose, can go on to other care, maybe EMDR or some other care, and actually do really well and are more likely to go and stay. We can also measure now in collaborative care with the PCL for trauma. And so just a couple of things to think about. But I have actually seen that. I've also seen it with alcohol, where I wish I recorded this guy one day, where he said to me, this is the first time that somebody talked to me about how I was feeling and not just my drinking. And really focusing on the daily symptoms, that he was incredibly anxious, and really focusing on that daily experience around the anxiety. And granted, we had to talk early in the morning before he started drinking. But actually, over time, his anxiety went significantly down, and so did his drinking. And so really just focusing on those symptoms. But thank you, Kim, for the question. We're gonna take that on actually now with this grid. And so when you think about like a model of care or what this really looks like, I like to think about it a little bit different. So let's not necessarily pick a model as much as let's just figure out what we need to do for the people that we care for. So some of the people that we care for have health and behavior needs, right? They need help smoking, or they need I'm going to call them a one and done, right? With a little intervention or some kind of a behavior change, or maybe a little medication support. And then we have, and that's a whole population of people, and that's what they need, and that's all they need. And then we have our measurement-based care group. These are people who have conditions that we can measure. So this is your collaborative care population. Then we have folks that fall outside for conditions we can't measure, early childhood, some people who maybe have multiple co-occurring, right? People who would really benefit from groups because there are no groups in collaborative care because of those monthly minutes. And so you have those populations of folks. And then you have folks that have really complex mental health needs. And so if I have individuals who are doing non-collaborative care, they're doing health-focused interventions, and maybe that's some people on our team. Some people are running groups and doing some for the other population. Some people are doing something for our complex patients, right? And so who do we have on our team? Who do we have that can help cover each of these buckets, right? What evidence-based practices are we going to do? So for measurement-based care, collaborative care is definitely there, right? But there's lots of evidence-based practices in each of these buckets that we can use, lots of different codes, lots of different resources. So I really encourage organizations, don't get stuck in picking a model, right? We're going to do PCH, we're going to do collaborative care. No, no, no. Let's think about who our population is, who we have on our team, what codes are available, and then start to think about how we care for each of these populations. And many of the people you find in measurement-based care. So I often tell people a couple of things. One is, if you ran a report of all of the patients in your organization that were on a medication for depression or anxiety and have never touched behavioral health, many organizations have hundreds or even thousands of those patients in the last 12 or 18 months. That's your collaborative care population. It's kind of thinking about, if I went in, right, to see Caitlin, and Caitlin put me on metformin. She said, you know what, Verna, your sugar is really high. I'm going to put you on metformin, right? And you're diabetes type 2 or you're pre-diabetic, right? And sent me out. And then we never measured my A1C. And I came back and I saw Caitlin, and Caitlin said, how are you doing? I actually think I'm feeling pretty good. I think this metformin, I think it might be working. I'm trying, and I'm not drinking as much Mountain Dew, and I don't feel myself being as shaky, sometimes, or tired. I think it's going pretty well. And Caitlin said, okay, well, just keep taking that metformin, right? But you never measured my A1C. We would never do that. Never do that. It would be terrible care. But actually, when you talk to your providers, that's exactly what's happening with your depression and anxiety, your ADHD patients. We put them on meds. We have no idea, for all the kids on ADHD meds, how often do we do a Vanderbilt or a GIPD? And how often do we look and say, you know what? Your hyperactivity's really gotten better, but actually your attention, not so much. All we have are the parents or the school saying, oh yeah, actually doing much better. We're not bouncing out of our seat. We don't have as many discipline problems. We're all good here, right? When in actuality, that kid isn't as good as they could be and is still really having attention problems. And so those populations are your collaborative care populations that you're really not tracking or monitoring now. And so just giving you some things to think about as you start to think about your different populations and what you need to do. And again, thinking about that population health approach. So I'm going to stop here for a minute and just answer any questions. And of course, we'll share these slides out, and I can share this grid out and, talk to you. But this is actually just a different way to think about caring for your whole population. Probably a little overwhelming. Okay.
Actually, this is probably one of the easiest ways I've seen it explained. Being in integrated health for the last 10 years at some capacity, this is probably the because to Kim's point, we hear those questions all the time. How do you treat this, and is this, are you not taking people away from specialty? And anyways, this is probably the easiest way I've seen this described. Just texted Kim and told her we need this for one of our other presentations. This is great.
Yeah, and then you can say, okay, well, you guys are going to do 1, 3, and 4, right? Or what do you do with your smokers or your behavioral interventions now? And oftentimes what I find is organizations haven't really thought about the one and dones. Like sometimes people really do just need a one and done, and oftentimes they self-select out because we put them on a therapy bus. They're like, why am I on this bus? I didn't ask to be on this bus. I don't know when it's going to stop. And so they just jump off, right? When really what they needed was kind of a one and done. And whenever I go into integrated settings and I ask, well, what do you do with the one? How many one and dones do you have? And they're like, what are you talking about? We don't have any of those. And I say, well, then you're missing a big population of people. Maybe I just need some help, short-term help with smoking, or maybe I just really need to learn some alternate breathing, and then I can try that. And if I need, I can come back for something else, right? And so really, a lot of times, even just opening that possibility for clinicians in integrated health settings, saying that should be a consideration each time or a discussion, so that you're really giving people the level of care that they need. And for every one of these categories, you should know, how are we successful? What are the outcomes? How do we know that we help somebody stop smoking or lose weight? How do we know depression got better? How do we know that we gave somebody medication support and it was helpful? And so really thinking about that across the board, and also what team members do we have? Because not everybody can do everything. The health and behavior codes, some people can't do them, right? Other people can. So if there's someone on your team, maybe they can. So it's helpful to then back into this with the people and the codes that you have and sort of personalize it for your organization. But this is a really different way to think. So when people tell me, well, we have behavioral health, fabulous, love that, right? But now think about this whole measurement-based care column, all of those people that are in that bucket. Now you're kind of expanding your offerings to include a whole new group of populations. And so that's really how to start to think about it.
And I'll just make a comment. Can you go back to it? I really like this depiction, particularly as it relates to one and done. I'm a physician and also the CEO of a health center, but we don't nearly refer for smoking cessation or obesity as we should, and the resources are right there. So I like that, and just to think of it a little different, and they could be, helped. And just thinking that as a provider, I can do it on my own, when really, rarely do I do that. So it made me think about, just referring more for those, one and done kind of, conditions. Because some people just kind of balk at, oh, I don't want to see, behavioral health. I said, well, you just see them one time. So I like that, and I need to pay a better, focus on that as well.
And actually also reframing to be able to say, I have a colleague that sat with some of my patients and done something called mindfulness. And it takes about 30 minutes to really learn and understand and practice. And many people find it really helpful for their eating and weight loss journeys. And so even that reframing for like a one and done is really incredibly helpful. And mindfulness is a great skill for people to learn. And then what happens is that person has a really good interaction with a behavioral health professional and says, you know what, maybe it would be helpful for me to have another time, or could I check in with you when I come back to see Dr. Ward-Jones, right? And so that actually, just to give you an example.
Right. Okay.
Great. Thank you. Any other thoughts, comments? Okay. Great. So giving some really just some very basic foundational understandings while we're starting to really Again, to really understand the model. That's what we're really going to try to do today, is we are going to really try to understand the model. So a couple of things, and you're going to hear a couple of things repeated because they're so important. And I went to the 8 times 8 ways school. So again, just bringing some things up. So here's a couple of things that we know are really important. So one, everybody has to understand the model. Not just your collaborative care managers, but all of your primary care providers, your medical leadership, everyone, your nursing teams, MAs, everyone has to really understand the model. We do not want to split staff. I have probably done, I don't even know how many collaborative care implementations. And whenever someone says to me, well, we have a social worker in our health center, and we're going to have them also do collaborative care and start out. I always go, ugh, because I know that on the amount of times I have seen that work successfully, I can literally count on 2 hands. And it is almost always a disaster. And it's a disaster for several reasons. One is nobody likes to say you're doing this and you're happily cooking along, and now we want you to do this completely different other thing. And also, you know, collaborative care takes a different approach. I have to put things in a registry. I have to be accountable for my outcomes, right? So generally what you find is that people say, oh, well, they really weren't a collaborative care patient, so I'm just going to move them into my traditional care. And you have very, very low engagement. And also, it's very hard to think about the scheduling for that. I have all these scheduled appointments, and then I also have to figure out how to really have a collaborative care caseload. And so it's really not helpful. I would way rather work with you on an accurate pro forma to be self-sustaining in 60 days, or to have you bring in a student to be able to become self-sustaining than to have you try to split. I would tell you then just wait. The other misconception is warm handoffs. Warm handoffs alone do absolutely not fill a collaborative care caseload. In fact, warm handoffs are kind of overrated, to be quite frank. There are many patients who benefit from a warm handoff. There are many who don't need it. And to say, you know what, I work with Kim and she's part of my team and she helps me care for my patients who are sad, like you talked to me about today. I'm going to have her give you a call this afternoon. She's pretty funny. You're going to like her. That actually is sufficient. And we've found that a good handoff, not necessarily a warm handoff, but a good introduction from a primary care provider can actually have engagement rates to 85 to 90% in collaborative care. I've seen that in practice, and you can tell the difference in terms of those conversations with patient engagement in collaborative care. So I just give providers that verbiage and I say, and then just keep going. And that's an incredibly important piece. And understand that most services are going to be remote. So I'm going to spend a moment here because collaborative care from the very early research trial is that we are going to be predominantly remote. It is going to be by telephone. It was in the early 2000s because part of collaborative care is very high touch. And so we are going to be doing this by phone. It just works better. The other piece is by phone. I can call people and set a short goal. And someone says, well, you know, I'm here. I just sit in the dark every day. And I say, well, what's something you could do today or tomorrow to be less sad? Well, someone told me that I should open my blinds. Well, what could you do towards a goal of maybe opening your blinds? Well, I could probably open my kitchen blind because I sit at the table. Well, could you open your kitchen blind now? Why don't we go, right? and we open our kitchen blind for the first time in years. And we do it together on the phone. What do you see outside? How does it change your kitchen, how your kitchen looks, right? We kind of celebrate it. And then maybe the goal is to have our coffee tomorrow morning in front of the open window. And so I'd love to give you a call tomorrow and see how that went. And so that's what collaborative care is. So remote works better. The other thing is I've had a lot of conversations with providers who will say, nope, my patients need in person, people want in person. A lot of times because they don't necessarily understand collaborative care. And oftentimes I let people know we've learned a lot about behavioral health treatment. Like we've learned a lot about caring for lots of diagnoses, right? Is that it is better in doses, like medication. That, and I sometimes joke, like you get a dose of me every day, right? It's better in these short doses. And so I really want to have us be in contact, and that just works better remote. And patients actually prefer it. I'm just finishing up a survey with 40,000 patients and their treatment preferences. And actually, they prefer the remote for collaborative care because of the different activities. I'm also going to say it's important to understand the outcomes. I went into an organization about 2 weeks ago that has been doing collaborative care for about 4 years. It's not going swimmingly. And I went to the primary care provider meeting to quote unquote retrain them. And not a single primary care provider in the room knew the depression or anxiety outcomes. And so they didn't know that we were looking for a 50% or 10-point reduction in the PHQ-9. They didn't even know about that. It was an FQHC about the UDS requirement for the 12 months, right? And so, which isn't a great measure, so we're not going to spend a lot of time on it. But really looking for, that's a whole other webinar in my whole argument with HRSA, but we'll go there another day. And so we're really looking for that 50% or 10-point reduction. That's in that 90 days. That's really important for providers to know, because then it's like, I'm not going to start you on a med and come back in 60 days. We've already gone through 2/3 of our time, right? That we're really going to be incredibly proactive. And so it's really important for everybody to know the outcomes, and that we want at least half of our patients to meet those outcomes. So very important to really understand and to know the outcomes. Share that with everybody across the board. Everybody knows the A1C outcomes. Everybody knows, some of the other outcomes, the BP outcomes. Share the depression and the anxiety outcomes, or whatever conditions that you're working on or engaging in collaborative care. Share those outcomes out. So I'm going to go through the core principles, and then I think we'll take a break. Is that right, Caitlin? I saw something in the chat. Is that correct? Okay.
Yeah, about a 5-minute break at 2, if that works for you.
Yeah. I had to look because I'm in a different time.
I forgot. I forgot. You're not here with us. Top of the hour.
No problem. Yeah. So no good. Yeah. So fine. So couple of things. So one is collaborative care is incredibly patient-centered. That means that I have the ability to really work with my patients to do what they think works best. Every day, every other day, once a week. Whenever I go into an organization, they tell me they're doing collaborative care, I ask to see their schedules. And if they have a consistent schedule, I know they're not doing collaborative care. No patient's schedule should look the same. If they're telling me they see people every week or once a month or something like that, I'm like, I know immediately 30 seconds in the door that they're not doing collaborative care. Very, very patient-centered, and it's going to change. Maybe I see Caitlin and we talk 3 times a week for 2 weeks, and then maybe the following week it's once a week, right? It changes. It is very population-based. It is really very hard to build a caseload in collaborative care without taking a population health approach. So if I call the nursing team and I want a refill of my sleep medication or my depression meds, somebody says, listen, it's really important that we know this medication is working for you. Let me ask you some questions. And if somebody scores above 10, then we know maybe that medication isn't working well and maybe they need to go into collaborative care, right? And so there's a best practice alert in the EMR that if I write a prescription for depression meds, I automatically get something that puts me in collaborative care or has me refer to collaborative care, right? So that it's everybody who has depression or anxiety or behavioral health condition has a care plan, has some support to be able to help them get better. So the entire population, and this is really a big deal for primary care providers because they really only had one choice. I send someone to therapy or they get nothing, right? It's like I'm here or they get nothing. Now it's this whole broad range of care that they could get, from just some light touches to touches every day, right? With all different evidence-based treatments. And so it's everybody in that population. It is incredibly treat to target. So most patients in collaborative care need at least 2 treatment changes. In fact, that's a quality indicator. And so very, very treat to target. I'm going to keep changing things. If someone's not getting better or getting worse, I'm going to change it up. I'm going to change it up. So very, very important to think about though that treat to target. So evidence-based collaborative care in an umbrella is evidence-based, right? The evidence-based model. Under that umbrella, right? All of those raindrops are all the other evidence-based practices that we know work for the populations we're caring for. If I have someone with depression in collaborative care, I use cognitive behavioral therapy, motivational interviewing, behavioral activation, maybe CBT, and I'm reframing a cognition, right? REBT, like DBT, I use all of those clinical interventions that we know work. I'm just pulling them out of my tool belt when I need them, and I'm using them at different cadences. I can reframe someone's cognition on a 15-minute phone call while they're opening their window blinds, you know? And so that actually is incredibly helpful for people. Most behavioral health interventions are actually 6 to 8 minutes. If I'm giving you some exposure for trauma or anxiety, if I'm teaching you a DBT skill, if I'm teaching you alternate breathing or progressive muscle relaxation or mindfulness, right? Those are 6 to 8 minute interventions to teach you. And then I'm like, hey, I'd love to give you a call tomorrow and see how it went. So it's that kind of teach it, follow up, teach it, follow up, skill kind of building that we're accountable to the entire population of patients. Collaborative care is 6 to 8 months. So that's generally what we see. If you're finding people are going more over that, you're likely not doing collaborative care and maybe need, I call it a drift, you're drifting. And so we need to reel you back. And also crisis. So a lot of times people will say, well, people who are in crisis or at risk for suicide, not collaborative care, they actually do really well because it's so high touch. I can talk to you every day and do a Columbia scale, do a safety plan, review a safety plan. So incredibly helpful for people to be able to do that. So these are the basic core principles of collaborative care. So I'm going to stop here. I know we're a little bit early, but I think it might be good to actually just take some questions like up to this point and then maybe take a break. Caitlin, does that work? Okay.
Yeah, that sounds just fine.
So any questions or thoughts about these core principles? Okay, well, if people think of any questions while you're having a bio break and getting a cappuccino or a water or something, then, you know, we can take them when we come back. And we've talked a lot about like some foundational knowledge, a little bit about what collaborative care isn't. Now we're really going to get into what it is. to really get a core understanding of the model and sort of how to roll it out, and what that looks like. So, I guess it's 10 of, so we'll take a break, Caitlin, until,
Since we've got a little extra time, why don't we just come back at the top of the hour? So 2 o'clock
okay,
for us.
just start.
Yeah.
Welcome back. With any questions about the core principles of collaborative care. Anybody have any questions, thoughts so far? And again, I do watch the chat, so if you're feeling shy, you can send it to me, but you know, we're a small, unintimidating group. Feel free to just unmute. Okay. Now we're gonna go where the rubber hits the road here, and really talk about what the model is. So this is a pretty picture, right? You've probably all seen this 100 times by now. Very much calling attention, and then we'll move on to sort of dotted line between the psychiatric consultant and the provider. So it is incredibly important that the two people we add to the team really understand the model, and that the team really understands that they are coming in as part of the team. So this behavioral health care manager and the psychiatric consultant are coming in to be part of this primary care healthcare team. Very high touch with the patient. So oftentimes people ask about the psychiatric consultant. Can be an MD or an NP, is someone who has access to the electronic health record. They absolutely have to have access to the electronic health record. And then they can document their consultation to that healthcare provider directly in the EMR. And there's some different workflows or places that it goes, but that psychiatric consultant needs to be able to have access and needs to be able to send that recommendation directly to the healthcare provider. And they also need to be on the team to be able to meet with that behavioral health care manager once a week. And so what are we sort of finding? A full caseload for a behavioral health care manager is about 90 patients. If it's pediatric, it's a little bit less, maybe it's 75 to 80 patients, but it's really around 90 patients. And so if I'm in a full caseload, really hard for me to talk to my psychiatric consultant once a week in just that 60 minutes. So we're finding with a full caseload, it's more like 90 minutes. And one of the things we know is that it's not like an open door. It has to be dedicated time. A couple of myths around the psychiatric consultant: that they need to consult on cases that are new. So if I'm new to collaborative care, I don't necessarily, as a care manager, need to bring my new patients to the psychiatric consultant for psychiatric consultation. If I have a question about diagnoses or medications or something, then absolutely. But as a process or a rule, new patients do not need to come to that psychiatric consultant. Patients that are leaving collaborative care, that I'm phasing out, that I've gotten better, do not need to come to psychiatric consultation before they're discharged or they go off with relapse prevention plans from collaborative care. So generally for psychiatric consultation, we prioritize patients. So patients that the primary care provider wants talked about, patients that are having side effects, patients that are at risk, maybe suicide, patients that are not getting better, meaning that I haven't gone up by at least 2 points, or I rather haven't gone down by at least 2 points, or if I've gone up more than 2 points, so I'm getting worse. Those are the people that come to psychiatric consultation. One of the myths around psychiatric consultation is that you have to have a psychiatric consultation for everybody in collaborative care every month. That actually started from CMS, that did put some language in their guidance. They have since said, no, we actually didn't mean that. It's not consistent with the model. and that for your Medicare patients, you do need to put some documentation in that psychiatric consultation was available to them, but you don't actually have to have the psychiatric consultation. So if people have more questions about that or want to talk about it, I'm glad to answer that. The behavioral care manager is someone that they don't have to be licensed, but they do have to be able to have all of the treatment choices or be able to provide all of the treatment choices that we're going to talk about. One of them is talk treatment or therapy. So just sort of keep that in mind as you're going forward. A registry is a required component of collaborative care. That's because we're taking this population health approach. There are a few electronic health records that can actually serve as a registry. Many of them cannot. MedEnd can, Epic can. The others don't have the functionality. And when I say that, what I mean is that they don't have the ability to prioritize patients to tell me which ones to bring to psychiatric consultation. And they don't tell me the PHQ scores over time enough to tell me who's gotten better or who's gotten worse. When you think about it, that's pretty complicated functionality to be able to do. And so there are options for registries. I know that you're working on that sort of as a group, but I'm glad to help or be a resource to anybody who has any questions or comments about a registry. There is no limit to the number of touches that behavioral health care manager can have each month with that patient. Telephone, video, in person, it doesn't matter. There is no limit to that. So I want to just stop and answer any questions about the model, or people have any questions about anything sort of. Okay. So we're going to do a deep dive into each of the roles. Let's talk about the primary care provider, healthcare provider first, because I always think they're like captain of the ship, right? So they are still overseeing the care, right? They're the primary clinician over the patient's care. They're the ones that establish that provisional diagnosis, although I'm going to note to my care manager friends in the room, and with all of my love to primary care providers, oftentimes that provisional diagnosis doesn't actually wind up to be the diagnosis once someone has time to really dig in, to get some information, to really do a diagnostic, right? And so, but they establish that provisional diagnosis. They may prescribe meds or may not, but if there's medications prescribed, they're the ones that are going to do the warm handoff, kind of like I said. I work with, Caitlin, she's part of my team. They're going to do that warm handoff. They're going to put the referral in the chart. So this is a really important piece. The clock does not start in collaborative care until that referral goes in the chart. I can talk to Caitlin today, right? I can talk to her about her depression. We can set some goals. We can do all of that. If there's no primary care referral in the chart, none of that time counts towards our collaborative care episode. The referral starts the clock. And so the primary care provider needs to be engaged in treatment. It's right there in the CPT codes. They need to review the recommendations made by the psychiatric consultant. They don't have to follow them, but they do need to review them. Although most of the time, I think they're welcome. They need to communicate back to the collaborative care manager or to the psychiatric consultant if appropriate. Make any treatment adjustments, add a med, change a med, something of that nature, right? So that's the role of the primary care provider. So the collaborative care manager, that's someone who's using all of those evidence-based practices that we talked about, all of that patient education, self-management. They're really making sure nobody falls through the cracks using my registry. I'm going to do any medication support that's required. I'm going to make treatment changes and facilitate those, and every patient's going to get at least 2, probably. I'm going to do relapse prevention and care planning. And for those of you who are PCMH or NCQA, think about how the care plans can actually fold into some of that other work you're doing, or closing the referral loop can tie into some of that other work you're doing. So now the psychiatric consultant. So the psychiatric consultant does that weekly caseload review. They make recommendations, and maybe it's around meds, or it's about labs, or around diagnoses, right? They're going to consult with me, the care manager. Maybe I was doing a differential and I'm like, I'm not really sure. This could be a complicated grief, or it could be major depressive disorder, not really sure. So I could talk to my psychiatric consultant. They're going to make recommendations. So you know what? Why don't you ask this or that question? Why don't you rule out actually maybe sounding a little bit more like ADHD versus anxiety? Maybe we need to rule that out, right? Or maybe there's a bigger sleep problem here. So let's really try to get to the bottom of that. So they're the ones making those recommendations. So it's not just around medications, it's around maybe a treatment modality, or labs, or over-the-counter meds, or anything like that. And that psychiatric consultation as a care manager, that's also a learning opportunity for me. And I should feel comfortable going and having discussions and asking about diagnoses or different questions, or saying, you know what? You put this patient on a medication, they're having some nausea. Tell me a little bit about this medication. I'm not really familiar with it. Is that one of the side effects, right? That I should feel comfortable having some of those discussions. So glad to answer any questions around the roles here. You guys are awful quiet.
I was going to say, Verna, normally we're not,
I don't know, little concerning. It's a little concerning.
that
Okay.
quiet of a group, but I'm just curious. I don't know if anybody does have questions about roles, or especially the behavioral health care manager. Looks like we've got a question.
Yeah, go ahead. Let me see.
Would the nurse practitioner be prescribing or just recommending a med change?
So in collaborative care, like, fidelity to the model, the nurse practitioner would not be prescribing meds or seeing patients, like as a rule in collaborative care. It is possible that someone could have, let's just say, boy, we can't really figure it out, it is possible that they could see someone one time, stabilize them, and move them back to primary care. But if someone is in specialty mental health and they're really not collaborative care patients, so the answer to your question is no, they're not prescribing, they're making recommendations to that primary care provider. Any other questions about the roles? And that's very different. You want to find a psychiatric consultant that actually believes that primary care can do this work, because we know primary care providers actually write more prescriptions for depression and anxiety meds than psychiatric providers do. And so they're already doing it. But a lot of times, I worked with a psychiatric provider the other day, and I got called in because they were referring everybody to specialty mental health. And so they were not a great match, because they fundamentally didn't believe that primary care providers should be managing some of these behavioral health conditions, even with consultation. And so you really want to ask some of those questions, or have some of those discussions before bringing that psychiatric consultant onto your team. Same with your collaborative care manager. They really have to understand and have a good sense of the model, really believe in, the model and evidence-based treatments, and using tools and measurement-based care. Okay. So now this is the most important piece. It is incredibly important to understand the treatment choices. This is like the absolute core of collaborative care. And I talk to so many care managers who don't really understand the different treatment choices. So the fun thing about collaborative care is that there are treatment choices. And we don't tell patients like, oh, here's choice 1 or choice 2, right? It's way more organic than that. And we'll sort of talk through it and go through. But it's really important to understand. So let's take the easiest one first. And so medication support, if someone is on medications, right? It's not about medication adherence, because it's really not about getting people to take meds. It's about developing a partnership with people around their decision to use medications and how they can optimize, right? And so really supporting them. I could say, you know, Misty, it's really hard to take medications every day. Tell me about some times when maybe you don't take them as prescribed. Well, you know what? I do pretty well during the week when I go to work because I have a routine. But on the weekends, I forget all the time. Like it'll be halfway through Saturday, or I'll remember on Sunday or on Monday morning last week, I realized I didn't take my medications at all on the weekend, right? And so then we can say, well, what's one thing you do every single day? So I had somebody the other day, right? I walk the dog. So you know where we put the medications? Right next to the dog walk stuff, right? Right next to the poop bags and the leash. There it was, right? And so that was actually incredibly helpful for that person. So medication support and really helping people, because a lot of times what we find is that people will say, well, I was on Lexapro and it didn't work. So tell me about how you took the Lexapro. And oftentimes we find that they didn't actually take it as prescribed. So people can say, well, I tried Lexapro and I tried this, but in reality, they didn't take any of them as prescribed. And so that often is incredibly helpful to be able to have that conversation and really say, well, what if we really tried to take it as prescribed? I also love to ask people, are there times when you take more or less of your medications intentionally? Oh, well, yeah, I take it on the weekends. I take 2 because I really want to sleep, right? But on Wednesdays, when I meet with my manager, I don't take it because I don't want to be groggy. And so you'd be surprised how often people tell you that they take more or less. So that medication support isn't really around adherence. It's actually supporting people in really working the medications and giving them successful trials around medications. The next one that is incredibly helpful, and I use honestly the most, and I find to be the most helpful. And here's actually a tip. It works just as well as at home with your family as it does with people that you're working with. And so I like to say, what's one thing you could do today or tomorrow? And my rule is if it's before lunch, I say today. If it's after lunch, I say today or tomorrow, that you could do to be less anxious, because I don't want someone to say to me, oh, well, I want to get a job and get along better with my mother or lose 50 pounds or whatever, right? I want them to really narrow it down right away and give me something smaller. And so behavioral activation is really incredibly helpful for people because it helps them really prioritize. And most of the time, goals that we set for people are way too big. One of my favorite things to do, and actually you can do this as part of your implementation, is go into a chart, look at all the goals that were set for someone and who set it, how many of them were actually accomplished. I've seen as many as 17 separate goals for people: diabetes goal, primary care goal, behavioral health goal, you know, this goal. And so most of the time it's too much, they're too big. I often see in behavioral health charts, patient will walk, you know, 3 out of 5 days. That's way too big. And so we really want to try to narrow that down into something that is almost foolproof to happen in the next 24 hours. So I have a good example just to illustrate behavioral activation, and we'll be doing, more deep dives. But this goal setting this is the gentleman who hadn't gone outside. His wife passed away. He hadn't done anything. And at first, all he was going to do was he was just going to he was going to go outside and just look at the garden that he used to keep. And then he did. And while he was out there, ran into his neighbor across the fence who gave him a tomato plant. And so then he wound up planting the tomato plant. And so gradually he actually got back into gardening and he started talking to his neighbor. So his PHQ score went way down, right? Because then he had stuff to do. He was engaging with people. He was going outside. So the person who says, I ask, well, what's the likelihood that you're going to walk every day? Your provider, you talk to your provider. Not at all. I wear my slippers. I haven't taken my slippers off, Well, what's something you might do towards your goal, towards a goal? What would you like to do? Well, I'd at least like to go outside. What would you need to do towards your goal of going outside? Well, I'd have to be able to sit somewhere because I can't really stand long anymore. What would you need to do towards your goal of sitting outside? Well, I'd have to get a chair, and all my chairs got put away. They're in my basement. What would you need to do towards your goal of getting a chair? Well, I'd have to call my son to see if he could bring one of the chairs up from the basement. Is there a time today when you think you could call your son? I'd love to give you a call tomorrow and see if you had a chance to connect with your son, right? So that's behavioral activation, that goal setting, really small goals, and then following up. Most of the time, the goals that we set are way too big for people. So we'll talk more about that in practice, but that is a treatment choice. And that's the one that I use most often, to be honest. The other is talk treatment. And the wonderful thing about talk treatment or therapy and collaborative care is that there's no limitation on it. I can say, you know what, Caitlin, it seems like you've got a lot going on. And so why don't we take some time and schedule some time to talk a little bit longer next week? So Caitlin's in talk treatment for that week. It can be for a couple of weeks. It can just be for that week. It can be that week and then again 6 weeks later. These can be interchangeable every week. So when I said there's no set schedule, that's because I'm in and out. Maybe I don't need medication support anymore. Now we're having trouble engaging. We're going to set a small goal, right? Maybe something's going on. We're going to do some talk treatment. Maybe we're doing all of them. And so, I can go in and out of those as needed. So you're not limited to any one thing. It's whatever is going to be the most helpful. Now, symptom monitoring, as an example, let's just say I talk to Misty and I am my most engaging, endearing self, right? And she's like, yeah, I'm not really having you, right? And so I say, you know what, Misty, it's really important that, Dr. Wade Jones know how well you're doing. You talked to her, you've been feeling sad for a while. What I would like to do is give you a call once or twice a month and just ask you some questions so I could let her know how you're doing. Am I going to chat you up when I call you? Totally, right? But that symptom monitoring is like the very basic. And so a lot of times we lose people in collaborative care because they don't even know that that's a choice. If I say, you know what, it seems like it's really hard for you to set some goals now or to take some time. What if, we just talked once a month or twice a month and I could find out how you're doing and let the doctor know, right? So we're giving people that option. And then a lot of times we continue to engage them in care and then they wind up going into other treatment choices. Also, symptom monitoring maybe towards the end, like in relapse prevention planning, although I tend to start that right from the beginning. And so that relapse prevention sometimes is symptom monitoring. And so these are the 4 treatment choices in collaborative care that you use all the time and are the very core. So a lot of times people will say, we'll wind up with a lot of people in talk treatment. And so only about 15 to 20% of your patients at any given time should be in talk treatment. To be honest, I don't even bring it up generally, because by the time I would even get to it, I'm already following up on a goal, talking to someone about medications, and I'm using the same evidence-based practices that I might do. And so, you know, there was somebody recently who lost someone, and then also had someone else diagnosed with cancer and be given like a spouse and a daughter. So I actually said, you know what, you've got a lot going on. Why don't we take some extra time? So I brought it up, right, for some talk treatment to do a little grief work with them. But that doesn't mean it needs to be every week. Or it could be twice a week or 3 times a week. I'm not limited. So I'm going to stop here and just answer questions or hear some thoughts about these treatment choices. Is this sort of what you thought? Does this make sense? Do you understand how it works and the flexibility?
Verna, I just have to say, and I don't know if others on the call agree, but the way you explained how this isn't scheduled and talked about the flexibility of the different components, I think is just so beautiful, because I think a lot of times, and I'll just speak for myself, but when we're trained, we don't always think about incorporating the flexibility and how I might, I might be working on problem solving therapy with someone, and then 3 weeks in, we hear maybe they lost a family member in a car accident, and so we might need to incorporate the talk therapy piece. So I love that, and I'm just speaking from, I'm getting old myself, but a clinician who has, been around practicing for a long time. I think sometimes it's hard for us to remember we can incorporate and pepper in lots of different components based on what the patient needs at the time. So thank you.
Yeah, and that's the really important piece, to have care managers that and primary care providers that really understand all of the different treatment choices. I can be in collaborative care for just medication support.
Yeah.
I can be in collaborative care for just behavioral activation. A lot of times you go back and forth as you change treatment, like people are in multiple. I use probably talk treatment the least, and quite frankly, because most of the time I really just don't need it. Like, it isn't going to serve any, I'm already talking to someone multiple times. And so really important to be able to do. Any other questions or thoughts about these treatment choices?
I think there's a question in the chat. Did you see that?
Did I miss it?
Yeah, and
Okay.
Dominique is our psychiatric nurse practitioner here at our health center, and she poses this question.
An example is a PCP collaborating with NP and prescribing an antidepressant and referring to the NP later, and the patient experienced mania after a few weeks.
Because in our model of care, there's the PCP, which could be a physician or a nurse practitioner or a PA. Then there's the care manager, and then there's the psychiatric nurse practitioner. Now, we do have access to a psychiatrist, but that's Dr. Pine, is just 4 hours a week. So, we use Dominique, in terms of this, kind of like the specialty care. But I think and you want to speak more on it, Dominique, in terms of how often this happens, or what can we do to avert this? Kind of give some context for that. You're still on mute. You're on mute.
Yeah, like during the collaboration, that's why I was kind of asking, like, is the nurse practitioner prescribing something then? I've had that, and then I've had where there's just questions about what to prescribe, and without knowing the patient or talking to them for that long, it's kind of hard to decide that sometimes. And then sometimes the PCP will prescribe like an antidepressant and then refer them for the whole evaluation. And then at that time they have some concerns, and then you kind of found out later it was something else.
So I think some of this is a training issue, right? So if I have some concerns and maybe I want to rule out bipolar, right? Then when I refer to the care manager, I put that so they could do the city, they could talk to you, they could get a bit of a history, have psychiatric consultation, and then make some recommendations, right? When you're doing your psychiatric consultation, you're going back through the chart, you're looking at the last notes, you're looking at the med history. And also, we're going to be training the care managers to get the information that you need so that they're not just telling you, listen, they scored a 2 on the sleep question. Like, they're not falling asleep. They haven't been falling asleep for 6 months. This has been so that you're actually getting the detailed information you need to be helpful with that differential diagnosis. But if you have questions or you need additional information, then to message the primary care provider or for them to message you, that should be, pretty, I don't want to say routine, but it should be something that could happen if people feel like it would be helpful.
Okay. That makes sense.
Yeah. And it is very different way to practice, and also really depending on the care manager to give you the information that you need, and also to talk to the primary care provider. Like I've had this come up before where they send, want to rule out bipolar, but it's like, what in your note? I don't see where in your note there was anything indicated to rule out bipolar. Like, do you just want me to rule it out before you're prescribing meds? And maybe here's another way to do it? Or are you ruling it out and because of some reason and just didn't document it? In which case it's really helpful for me to see that documentation going forward, so that we can make a recommendation. And I think it's medical leadership around if I start someone on meds and then refer them, that actually now they would go in collaborative care and you would be reviewing and making the recommendations versus seeing that person. And so it helps you touch more patients, right? You're a valuable resource. So it helps you touch more patients in terms of making recommendations and seeing the people that really, really bubble to the top that need your expertise and hands-on. Does that make sense and help answer?
Yes, it does.
One of the important things for medical leadership is that there has to be some consistency. We can't have one provider that says, nope, I'm not touching any behavioral health meds, not even first line. And someone else that says, yeah, I'm pretty comfortable with mood stabilizers, like bring it on, right? Like you have to have at least some consistency that everybody is on board with first line meds for depression or anxiety. Otherwise, quite frankly, you get some mayhem because then patients go to the providers that they can get the meds because there's no behavioral health access. You wind up with people that really could have been managed in primary care and you get backed up. And so it really is helpful to have that baseline consistency.
Yeah, and that's easier said than done, though.
It is. Yeah.
Yeah, and I was gonna say, I think we kind of talked about earlier or another time. I'm okay with like same day, just to talk to them a little bit more than like 5 minutes. So same day, next day. But if you get further than that, sometimes they don't come or they don't come back.
Right.
Yeah. Yeah. And that's why collaborative care is really helpful because that care manager is talking to that person every day. So you're going to be able, or every other day, or has that close relationship. So you can get the information that you need. Any other questions, comments around the treatment choices? Okay. That is a really big part. And again, I'm going to say they can change whenever will work for them, change from week to week, be in multiple, right? Nobody should look the same. Nobody's schedule should be the same. And I know it's really hard to not do that, to say I'm going to see people every week or every other week. It takes some practice and it takes some thought about how to arrange that in terms of, you know, only telephone or outreach or what that looks like. But that's a really, really important piece. So talking a little bit about the journey so that you can conceptualize it, right? So people can be identified through screening. So whether it's the PHQ or the GAD or someone has symptoms, and then they have to put the referral in the electronic health record. So we start the clock. You should really have same day, next day outreach. So if you want to do warm handoff, that's cool. But if not, again, you know, I work with Caitlin. She's part of my team. She helps me care for my patients who are anxious. I'm going to have her give you a call later today. That's perfect verbiage. Patient is then engaged in care. I call someone up, right? I engage them in care. We want to really work with them to reduce symptoms. So I'm going to be talking to them pretty consistently using those interventions to reduce those symptoms. I'm going to getting my psychiatric consultation in the electronic health record. Maybe I get medications, maybe I don't, off of those recommendations. And then we're going to work with someone until they're in remission or subclinical. And this is really important. You want to get people below 10, but also below 5. You want to get people down to where they're subclinical. And oftentimes people say, well, I did a 50% or 10-point reduction. Nobody should be coming out of collaborative care that's still above a 10. Some people, it's going to be as good as it gets, around a 7, but it should be documented. But the goal is to really get people below 5. So many times I see people discharged from collaborative care and their scores are still well over. And it says met treatment goals. And that's because the treatment goals were not symptom-based. Treatment goals need to be symptom-based. I tell care managers all the time, if you find yourself talking about something besides symptoms, reel yourself back, you're drifting. So we really want to make sure that you're focusing down and getting those scores, and your goals should be based off of symptom reduction. It shouldn't be anything outside of what that looks like. So let's talk about the time-based inclusions, right? And what's included in the time for collaborative care. So psychiatric consultation. So the time that I'm talking to Dominique is counted. However, it's only counted once. Dominique doesn't get to count it and I get to count it. If her and I talk about Misty for 6 minutes, then it's 6 minutes in that collaborative care episode. Usually the care manager counts that time and documents it. Any discussions or case reviews with the primary care provider. So the primary care provider can add that time onto their E&M code. Again, it doesn't matter if it's an FQHC as much, but the time and complexity could increase. The care manager can document that time in the collaborative care episode. Any time that I spend updating the registry, not the EMR, the registry. Anytime I'm on the phone with the patient or any collaterals, right? I'm talking to someone's husband or wife about the PHQ. Anytime I'm on the phone, anytime I'm talking to a patient in person, right? We're there together. It's got to be documented. Notice a couple of things. Case management or concrete services are carved out. If I help someone with transportation, with food, with housing, carved out, not included in the episode. These are treatment models. That is not treatment. I'm not saying that SDOH doesn't contribute to people's mood. That is not what I'm saying at all. I'm just telling you what can't be counted in a collaborative care episode. So a lot of times there's a misconception with the word care manager. And also, oh, well, we could have a CHW and they could do some collaborative care. No, those are actually carved out. And so really important to understand that. If the registry is in the EMR, then it doesn't count. You can't count the time. So if the EMR automatically populates the registry, then you can't count it. If you have to go into a separate portion of the EMR to put things in, then that would count. So the other thing, let's talk about outreach. So if I try to call Tamika 5 times and she doesn't pick up, then that counts, right, towards my time, but only in the first month, not in any subsequent month. So if I call Tamika month 2 and 3 and she doesn't pick up, or I'm leaving messages, that time does not count. If you look at the CPT codes, outreach is only included in the first month. The other piece to really pay attention to is we want to make sure that 90% of our patients are billable, so that we're putting in enough time for them to be billable. So any questions about what's included or not included in the time?
Yes, we had one question, Verna, in the chat, which is, what if the registry is incorporated into the EMR?
Oh, I actually answered that real time. Yes, so we did that one. But glad to answer if Tisha, that didn't, so you're in Epic, is that what you are? Yeah, so if I'm documenting and it's populating into the registry automatically, then it doesn't count.
Yeah, you answered it like right as after I put it in, so thank you.
Yeah, okay.
We're not yet, but the plan is to do that, so.
Yeah, and now if you're using another registry like CMTS or an Excel spreadsheet or whatever, you can count that time. One of the biggest compliance risks actually with the time is that care managers will say, oh, outreach time 1 minute, updating registry 2 minutes, and they use the same time every single time. That's actually a really big compliance risk. So I keep a timer actually on my desk, and I look right now in my world, it says 3:45. If I call Tisha and I leave a message and it still says 3:45, I put 1 minute. If it says 3:46, I put 2 minutes. That's generally how I do it, so that it actually is more real time, and then I have a process that I can then speak to. I actually run a report in my organization when care managers enter the same amount of time more than once or twice for particular activities, because that means that they're just standardizing the time, and that's a really big compliance issue. So we want to make sure that we're really paying attention to that. So here's some common questions. So is collaborative care telehealth? The answer is no. Collaborative care has a lot of telephonic components, but collaborative care is actually not telehealth. The codes are not telehealth codes, and telehealth and collaborative care are apples and oranges. So sometimes if you're implementing collaborative care and people get caught up in telehealth, tell them, no, no, no. We're barking up the wrong tree. These are not telehealth codes. Do I tell patients about collaborative care? I actually never use the words collaborative care. I don't tell people collaborative care. I don't tell them about the model. I don't do any of that. I just jump right in. So when you were in today to see your provider, you talk to them about how you've been feeling sad, and you've been feeling sad for a long time. Tell me about sad. You got a medication today. It's hard to take meds. I just literally jump right in so that it is incredibly helpful, just to literally jump right in. So do we need consent, and who can get it? So CMS learned from the chronic care management when there were literally like 9 patients in the country that had assigned consent for chronic care management, right? And so collaborative care does not need a signed consent form. People do need to consent. Right now, the primary care providers have to get the consent. That language is going to be changed in CMS probably in the next year, that anyone on the care team can get the consent. But right now, it's the primary care providers. So whether it's a checkbox in the EMR, whether it's the process of putting in the referral and some documentation that they talk to someone, it doesn't have to be this specific thing. They obtain the consent. Most of the time, the care managers are the ones who actually reiterate and then talk to patients, and we'll talk about this a little bit later, co-pays or anything like that. They're the ones who actually kind of go through some of those pieces. So what does an intake look like? We're going to talk about that at a future training. Intakes look very, very different. It says intake in the CMS requirements, but there's nothing there that actually defines what it is. And so we don't need a 60-minute intake. We don't need an in-person intake. If you're doing that, you're actually drifting away from collaborative care. What do I need to know? I need to know information to do a differential. I need to know what's worked in the past and what hasn't. I need to know if you've ever been in the hospital or the emergency room for whatever it is, right? I need to know those basic things to be able to start care, but I don't need this sort of longer process. And we'll talk a little bit about, I actually use the tools, and we're going to talk about why we love tools in an upcoming webinar. And how I use them is I actually, if you score a 0 or a 1, that starts to populate your relapse prevention plan. If you score a 2 or a 3, then that starts to populate your care plan. And then I do the tools as a discussion. I never just ask the questions. And in fact, I don't generally ask them in order. There's nothing written that you have to ask the questions in order. I start with eating and sleeping. Generally, I start with sleeping first, because then I can ask about sleeping, staying asleep, not falling asleep. It helps me with my diagnosis. And also I can ask questions that my psychiatric consultant will need to know. Are you not sleeping because you're worried about something, right? So there I'm ruling out a little bit of anxiety. And so that's really important to be able to do. And then I say, well, sometimes people who aren't sleeping have trouble concentrating or find themselves moving slowly, right? So I'm going through the questions, but I'm asking related ones. And so that actually is incredibly helpful. There is nothing standard for a first contact. I actually just roll, tell me about SAD, or I can see you just got a medication, right? And if someone's just going to get medication support, then I don't actually need to, I just need to really work with them around that. And so it can look very different. But if you find yourself setting up processes or policies that somebody needs, like this special intake, we're going to schedule. The minute you say schedule an intake in the same sentence, you have, your ship has sailed from collaborative care. So you need to bring it back to the doc, and you need to rethink about what that looks like, because it should just happen in that moment, and it doesn't have to be a particular time. So what does success look like? So very important. And I always tell people, and Patty and Kim are going to laugh because they've heard me say this. In all of the implementations, I can tell you one thing that's almost a guaranteed success and one thing that's almost a guaranteed failure. So really engaging people into care is absolutely critical. If a full-time care manager is supposed to be at 90 patients, 30 patients the first month, 60 patients the second month, 90 patients the third month. And this is come heck or high water. I don't care if you have to pull a little team together and talk every single day, try something different, look at provider schedules, talk to the providers, do some outreach, figure out what works. It doesn't matter. Your entire team says by the end, if we're launching June 1, by the end of June, we're going to have 30 patients enrolled in collaborative care. And whatever it takes, we're going to try different things. We're going to do it. The second month, we're going to have 60. Here's why this is so important. First of all, your care managers don't really get their groove and figure out how to manage cases until they start to get the volume. So at 30 patients, they're starting to really figure it out. The providers are going, oh, I kind of get this. I get how this looks different. Your billing people go, oh crap, we got 30 claims. We're going to have 60 next month. We better figure this out. And then you've got enough claims out the door to know if there's a problem with a particular payer and to really understand what you're going to get reimbursed. At 60 patients, most organizations are self-sustaining. That's incredibly important. Now your care manager's really figuring it out. You're working out any glitches. You've got this patient engagement. You've got some good flows. You know where to find your patients. Things are really cooking. 90 patients the third month. Organizations who do this and follow this are off and running. I have literally had organizations that have been implementing collaborative care for 10 years. And then we've come back, we've relaunched them this way, and they've been off and sailing. If you have 10 patients and you have 5 patients, if you start a care manager and you don't get them to that 30 patients and they have 5 and you're like, oh, we're starting slow, or we're just going to pilot with one provider. No, 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 no. 30, 60, 90, get them up and running and you will be smooth sailing. If you start slower, you're just going to limp along. And it's going to take you a very long time to get there. Know the outcomes, your 50% or 10-point reductions, your care managers should know that right from the beginning. Pop health approaches, 90% of your episodes billable at the end of the month. So if I go through all of my cases, 90% of them should be billable. Here's where people often go wrong here. Is that they keep people on their registry or their caseload too long. I don't carry people from month to month. If Caitlin is on my caseload and I try to outreach to her 3 times, and generally the way that it works is I call Caitlin and I leave Caitlin a message and I say, Caitlin, I'm going to call back, because most of us don't pick up our phones, right? But then I see the voicemail. I'm like, oh, that's Verna calling from my doctor's office. They said she was going to call, right? So then I'm going to pick up when you call back. That works incredibly well. Then I leave a second message if I don't get you. I leave a third message. The fourth message, I say, listen, sounds like maybe this isn't going to work for you now. I won't be calling you back. You'd be surprised how many people go, oh crap, I better call her back. I've been meaning to, but now I need to really do it, right? After that 4 times, maybe you have the provider call her, the nurse call her, whatever you do, but then that's it. I don't carry them from month to month. They can always come back. I let the primary care provider know. They can see my outreach in the chart and I move on. Unless Caitlin comes in the last couple of days of the month and I don't get a chance to get all those calls in, then maybe I carry her over. Otherwise, I don't carry over from month to month, so that my caseload is actually my active patients at any given time. And then I don't get cluttered with people that are not engaged in care. And so you definitely want to try to do that so that you're really moving people through your system and what that really looks like. And so you want, then it's easier for 90% of your episodes to be billable, because you're not then having people that aren't engaged in care. I had someone the other day, they had 86 people on their caseload. They only billed for 30 because more than 40 of them weren't actively engaged and had been on that registry and that caseload for months. So move people through. And then we want 90% of my time to be attached to an episode. So I shouldn't really be doing anything that's not getting attached to that episode, if that makes sense. So before our break, we're going to get in what people are really eligible or appropriate for collaborative care. So anybody with a PHQ or a GAD greater than 10, depressive diagnoses, and anxiety is a big umbrella. Your generalized anxiety, your phobias, social anxiety, panic disorders, PTSD, right? Anybody 12 and over generally falls into those buckets with those tools. However, we were talking about it a little bit after break. I can share a pathway and tools and outcomes for the 6 to 11-year-old. So if you're doing pediatrics, I can give you a really nice pediatric pathway, really nice ADHD pathways with tools and talk about it. We actually use the Vanderbilt for the initial and then the GIPD to measure ongoing. Your substance use disorders, great with special populations. If you have MAT services, HIV services, pediatric, women's services, all incredibly helpful to be able to do. So really important to be able to do some of those things. And then really looking at measurement-based care. So for suicide care, the Columbia scale, looking at that risk reduction. Am I scoring positive and then my risk is getting reduced? Really good collaborative care. The patient mania questionnaire for bipolar, the PCL for PTSD. I have some outcome measures for that. So again, that whole measurement-based care column is actually really important. And then you can use that. So for any diagnoses that you can measure, then you can actually put into collaborative care. So I know we were at time for break. I just want to ask any questions about any diagnoses or inclusion in collaborative care. Okay. So I guess it is right now 3 o'clock your time. So we'll go until 3:05. And then I guess we'll pick back up.
I do have a question though regarding that 30, 60, 90 recommendation that you have. What do you typically see as a barrier to hitting that census, the 30 patient census? Is it kind of an accumulation of things?
Yeah, generally it's because people are really stuck on warm handoffs.
Okay.
And then they don't get the volume. They don't think about the pop health approaches, or they're like, we're going to pilot with one provider. And then they don't actually work with that provider to identify, like, to say to that provider, if we were going to get to 40 referrals this month, then how would we do that? Right? So let's look through your schedule now for the month and identify people together. Let's run a report of all your patients on medications that aren't known to behavioral health. Let's, look through your patient panel. Let's look at the patients that are calling in for meds, right? Like, so that you're really coming up every patient that you're going to start on meds or refill meds, like put some of those parameters in right from the beginning. I don't actually suggest starting with one provider. Like, why? Unless you've got 30 providers in the practice, then maybe, and then you roll it. But if you have a couple of providers in the practice, then just go ahead and do it. Train everybody, let them understand it, and then just do it.
I was thinking that I think that conversation there just highlights the need for every single person on the care team to understand the model from, I mean, obviously you want your providers to, but all the way down to the front desk, or rather say all the way to the front desk, because it does take every single person there
it does
to get that census. So that makes sense.
And empower your MAs or your nurses to make referrals if somebody scores positive, and to have the providers then sign off on them as a workflow. The other thing is that if I'm a care manager, well-meaning, right, and I have 5 patients or 10 patients, first of all, what do I do with my day, right? But second of all, I tend to drift back into the therapy model because I got plenty of time with people, right? And so you tend to see that drift. So this way they really are sort of more forced to learn the model. They do much better.
That makes sense.
Okay. So thinking about primary care education, really important. Train every single primary care provider. Think about new providers coming in. And again, some of those things I talked about for the population, and avoid language like therapy or program. This isn't a program. You're not sending me to therapy. And a lot of times giving people language, a lot of times patients will come and say, my provider said I needed therapy. And say, well, we've learned a lot about behavioral health treatment. And what we've learned is that therapy is better in doses. So I don't say I'm not going to give you therapy or you're not going to get therapy, right? Which is a lot of times what care managers sort of move to. It's no, fine, we're just going to give it in doses because we've learned that works better. And then really taking those population health approaches. So really good language to be able to look at. So here are the codes that you're really gonna be needing to know. And then for some FQHCs in the group, we'll talk about what that looks like. So this is really all of your commercial plans will follow the CPT codes. And then for non-FQHCs, Medicare and Medicaid. So these will be across your whole payer mix. For FQHCs, CMS was not kind to FQHCs and made it a little bit more complicated. So my first month of care, 70 minutes. I notice outreach and engagement is in there. Notice it is not in the other. Follow-up months, 60 minutes. Again, there's some relapse prevention planning in here. There's some ongoing screening and monitoring in here. The 99494 is the add-on code. So generally, most commercial plans will pay for 2 of those a month. If you wind up finding yourself using more, you've probably drifted away from the model, sort of as a rule, right? So you really want to try to go back. Thanks, Patty. And then there's this general code, the 99484. I call it the code of last resort. You have to have at least 20 minutes. And then you can bill it. So if you don't make the time for the other codes, you can use this one. So remember also the half+1 rule. So the half+1 rule is in the CPT guidebook. And essentially for the first month, if I make 36 minutes, so half 35 + 1, then I can use that CPT code. I can use it for the 99484s, but only if I've used the full minute. So I can't do 31 minutes and then 16 minutes with a 99494. I have to use all of the 60 minutes for my 99493, and then I can half+1 my 99494. My very strong suggestion is at the end of your first billing month, I am glad to do it, Caitlin, whoever, Kim from the team, I go with a care manager, we go through their patients, they tell me how much time and the payer, and we code them together. Because then I ask them, did you include this? Did you include that? And then we talk about what code. And that often, once people do it once, then they tend to be pretty much off and running. There is the G code. A lot of people tend to not use this code as much. But it is for the first 30 minutes in a month. It kind of gave people a little bit of an out. There are times when if you use this code, right, and you use the half+1, so 16 minutes, it actually pays more oftentimes than a 99494. And so or a 99484 rather. So you oftentimes want to really think about what that looks like if you can use it at times. So dual eligibles, so patients who have Medicaid and Medicare, we want to bill the first primary one. And when Medicaid does not pay, then you can bill over to Medicare. So there's Medicaid may not pay, or some payers like Anthem doesn't recognize the 99484 as an example. So when we think about what some of the considerations will be, there's going to be some considerations for Medicare based on sort of where you are. Medicare does adjust by a nurse practitioner or a mid-level provider. The rates do change yearly. So patients can be in chronic care management and collaborative care unless you're in FQHC. If you're in FQHC, then you cannot be in chronic care management and collaborative care. Generally speaking, people will move to collaborative care and then move back to chronic care management just because of the reimbursements. And also, if my depression isn't better, my diabetes is not likely to get better. Think about other specialty providers like your cardiology or your addiction, your MAT treatments or providers. There might be higher copays for the specialty providers, but definitely include them. And so that actually is a super important piece. So for our FQHCs at G511 and 512, so interestingly is that the monthly reimbursement is going to be that 60-minute, reimbursement. We weren't kind to the FQHCs. The recent change is that G511 can be billed multiple times in a month. So we're going to do a deeper dive, but I just want to lay some foundational knowledge now. We'll be doing much deeper as you sort of go forward and move on this journey. Most organizations or most payers, actually all of your payers should pay. You should have no problems getting paid for the collaborative care codes. Again, there's 2 494 codes. Many payers don't pay for more than 2. The commercial rates will be the same as your commercial contracts. So if you negotiate your commercial contracts for 100% of Medicare, you'll get reimbursed 100% of Medicare for these codes. They were auto added, as we sort of talked about before. So the thing about staffing is that there is something in the Medicare guidance that says someone needs to be available if requested in person. Most of you won't have a hard time meeting that, but staff can be remote. They do not have to be on site, and then you could centralize them, which is kind of nice, and then plug in to cover gaps. We don't need to credential them because they're not going to be billing the plans. So you can actually really expand your staffing, right? So somebody who's waiting for licensure or somebody who just graduated, all it says is that they have to actually be trained in collaborative care and be able to provide all of the treatment choices. So the thing about individual visits, you can technically do individual visits and bill for them. I am really not a fan of this, particularly in the beginning, because people get confused. It's too hard for the care managers. You often don't need it for sustainability. And if you do, we can talk about how to do it. And then what happens is we find out that collaborative care is happening over here and therapy is happening over here. And if you're going to bill for both, you actually have to do both. And so I looked at notes the other day and they were talking about the relationship with the sister and all this stuff. And then over here, there was someone else doing a GAD, but there was no reference to the GAD in the therapy note and no reference to what was happening in therapy by the person doing the GAD. And so it was literally like these 2 parallel tracks. I don't even think the patient knew that they were connected. And so you really want to, I don't really encourage you to do that, especially from the beginning. And so really doing a good pro forma and figuring it out is really helpful. But it just really gets confusing for people. So when we think about submitting some of these claims, you're going to see way less denial rates for these than you do for some others. You want to really, there is no time limit. So someone could actually be in collaborative care for longer. Most payers don't actually put any requirements. There are a couple that require authorization for more than 2 add-on codes. But when you think about a pro forma, think about your average reimbursement and then multiply it by 90. And a caseload of 90 really works, because if I'm doing therapy, 90 doesn't work. But if I have multiple different touches, some in symptom monitoring, some in behavioral activation, some in talk treatment, then 90 actually becomes very doable for care managers. Again, pediatrics sometimes a little less because you have families and the tools are a little bit longer. And sometimes geriatric, if it's only geriatric, a little less, just because they tend to be talkers and sometimes have trouble hearing, or, you know, it just takes a little longer. Sometimes you have more collaterals. And so little bit of a difference, but generally sticking around that 90. And making sure, again, that you're optimizing so that you're really using that 1/2+1 rule to be able to apply. So want to make sure that this 484 that people understand, it is not recognized for the FQHC providers, so you don't get to use this code. Sometimes it can be used for the first month if we don't make enough time. The big payer is Anthem that doesn't actually pay for it. But I wouldn't actually worry about it. There are some payers who route it through behavioral health versus like the collaborative care codes that go through primary care. But I think more and more we're getting around that. I think the best thing to do is to start dropping some claims. If you have a problem and you get a denial, most often it's actually because there's a problem on the claim form as opposed to it actually being denied. Sometimes if you have a smaller local plan and maybe they haven't gotten these claims before, you have to do some problem solving. But for the most part, you shouldn't actually have any problems with these codes. So co-pays, so just like any other service, there are patients who have co-pays, particularly with some of the smaller plans, you know, that reset. So you're going to have some patients with high deductibles, and these are going to count towards the deductible just like any service. So the nice thing about the monthly case rate is that if I pay $20 to go see my primary care provider, I'm likely going to pay $20 for a month of collaborative care. So that makes this incredibly affordable for your commercial and your Medicare patients, as opposed to a copay every time, every week that I see a therapist. So it's incredibly helpful for them. The other thing to think about copays is I actually will talk to patients about copays, but I don't talk to them about copays right away. I give a little medication support if they need it, and then I set a goal. And then I say, you know, me following up with you and doing some of the things we just talked about is part of your insurance benefit. And it would be what you paid for your primary care visit today for a month. I really let people know what it is, because otherwise they don't actually know what they're consenting to pay for. And they're just like, no, I'm out. And so the worst that happens is now they have a goal, right? And they have some medication support, even if they decide they're out because of the copay reason. And so I always tend to do that with people with copays. But you will see higher copays if you have like cardiology or specialty providers potentially. So oftentimes where we see the big pitfalls, the land of perpetual launch that I talked about, the claim forms being incorrect, and no real focus or dedicated staffing. I want to stop there for a minute, and we're not going to do a super deep dive into the billing and the coding, but I want to answer any questions you have about the codes or the time. Well, usually the chat's blowing up right now. I'm so surprised.
I was going to say, I think that we have two two FQHC systems on. I don't know that either of them are billing the CoCM codes at this time.
Yeah, we're not.
Okay.
Yeah.
We're looking at those. I talked to my billing manager on yesterday, so we're gonna see how we can incorporate that, but we've not been using those.
So you could, what does your payer mix look like? Like what percentage of Medicare and commercial do you have?
In the behavioral health world, is it
No,
mostly?
in general, in your organization in
In
general.
general, we have mostly Medicaid, then Medicare, then commercial, and then uninsured.
Uninsured. So I would say a couple of things, you know, your Medicare and your commercial are actually going to be fairly revenue producing for you, even though it's not a huge population. And then, you know, you could drop your Medicaid claims, or not drop them rather, but just not drop them, but hold them, because then you could go back to the state and say, like, this is our uncompensated care, you know, for our Medicaid population. The other thing that you can do for your uninsured, one is you could put on your sliding fee scale, and you could bundle collaborative care so that it's there. But also then if you track those and you don't bill them, or you drop at least one bill, then you could meet your HRSA requirements, but also even think about, you know, your 330 money and, you know, future cost reports or whatever until Medicaid approves the fee schedule. But I would really encourage you to use the codes, even if you don't send out bills for your Medicaid population.
Right. Yeah, and we talked about it, so we're gonna, you know, I got with the billing manager, so we're gonna all get together and look and see how we can begin to incorporate.
Yeah, I think we're not going to be able to change Medicaid in the state unless we really go back with some significant numbers and data. These are the amount of claims that you would have actually gotten. These are the patients. These are the ones got better. You know, I think that's going to be the most helpful way to be able to do it. So thank you for taking that on and sort of moving that forward. I would also encourage you, and again, for the FQHCs for your Medicaid population, not so helpful because it's not a bill above, but also while you're thinking about this, to optimize your screening. So for your commercial plans for Medicare, are you billing for the screening codes? Is that revenue that you're getting? Because it does add up over time. So we can talk about that and sort of optimizing some of those things. So I want to try to stop there. I wanted to actually, I count on a little more discussion during, but I wanted to stop there and really just answer questions. We've got some questions in the chat I want to take before we move on. And, you know, we're going to really, you know, we have 3 of these training sessions, so we're going to be, you know, really taking some deep dives. You don't get rid of me after today. You get me 2 more times to really do a deep dive into some of the billing. And also, it's one of my favorite ones to actually go through, is really using the tools. There's so much around how do you actually use the tools. And that is a skill that we actually don't teach the care managers, and it becomes perfunctory, or places put in these rules like, oh, we have to do the PHQ once a month or the GAD once a month. That is actually the absolute wrong approach. We really need to use them interactively every time. We also don't want you to do the PHQ and the GAD every time or from the beginning, because then that sits in your data. So we're going to do a deep dive into really using the codes or the tools. What does it look like? How do we use them for an intake? So really thinking about that. And you should definitely be billing for some of the screening. It's revenue that adds up. And so the problem is, thank you. Yeah, is that most of the caseload is Medicaid. Yeah, that stinks. In terms of the decision by the state to not include Medicaid. Sorry, that was uncensored. But I wouldn't tell you something that I wouldn't tell them. And so I think the idea is that if you can get enough patient data here, most of the time states really worried, oh, we're going to get inundated with claims. This is going to be incredibly expensive. That actually has never panned out in any of the other 33 states that have passed the codes. And also, just like Patty said earlier, they're seeing documented cost savings. And so the ROI is incredibly important, but I don't think we can move the needle unless we get some data from all of you. But I am really glad to be able to, do a deeper dive into billing, and then next time to really talk about the tools. But feel free to be able to reach out. So any questions about the model, any barriers that you might have, foundational knowledge barriers that you might have to implementing and getting this up and running?
Yeah, I just think being more knowledgeable, particularly about the billing, and then just the whole kind of model and what that should look like, particularly in our organization. And I see some missteps that we are taking that we need to rectify. So this has really been really, really helpful.
I'm glad. Yeah. Any other barriers that you all see?
Hello, can you hear me?
We can.
Hello, this is Dr. Embry from Boston Mountain over in Huntsville. I was wondering, one of the concerns that we have here, we're talking as everybody else is talking, is the sustainability. And I think Dr. Jones also was mentioning that as well. Our Arkansas caseload at the local clinic where we have behavioral health with primary care is somewhere around 90%. And we see the need, and we can certainly document, and we can get the numbers, and we may even be able to get the outcomes. I think we're having a trouble with modeling the sustainability for administrative support. I was wondering if there's, when you start talking about the billing and the caveats of that, if there are some pearls outside of what you've already mentioned that may be helpful.
Yeah. So one of the things that, you may need to do, it depends on your payer mix, right? And what your reimbursement is for your Medicaid and your Medicare. So generally, I take your payer mix, and let's just say for ease of math, and remember, I'm a behavioral health person, not a math person. And so you have a third Medicaid, a third Medicare, and a third commercial, just for fun. And so then you can realize, okay, if a third of my caseload was Medicare at this reimbursement, and a third was Medicaid at this, or commercial at this reimbursement, then how much would I have? And what's the difference between that and what I'm paying my care manager with fringe and overhead and my psychiatric consultant? What's the gap there, right? And so then you can do a couple of things, right? One is you can say, well, at 70 patients, Medicare and commercial, we're self-sustaining. And so then we can take 30 Medicaid patients at any given time. Or you can say a percentage of those patients are going to be in talk treatment. So we're going to bill our PPS rate for those talk treatment sessions to make up the difference. Or for those, we're going to do our brief intervention calls at the minimum amount to bill a telehealth visit for our PPS rate. And so you kind of have to play with that a little bit, but that's unfortunately the way to do it. And then you can be self-sustaining. It is a little bit of a model drift, but probably if you can bill the telehealth visits, that's the easiest, more model consistent way to do it. The difference is you have to make sure that you're meeting the CPT minute requirement for those codes. But generally with the 1/2+1, you're at 16 minutes or 20 minutes or whatever it happens to be. So it's not terrible, but that might be the way to do it. And then I would still think about a way to track, that, because that ultimately is more expensive for Medicaid. Like ultimately you wouldn't be billing those codes, you'd be billing the case rate. And so somehow we have to figure out how to show that. But that was probably a long-winded answer, but glad to think it through with people.
I appreciate that. Thank you.
So the sustainability I know is a piece for sure. And that's why I really encourage a pro forma. Know what you're getting from Medicare. It's public information, you know, your rates, know what you're going to get from your commercial, and then you're going to know how many patients you need to have to be self-sustaining. And that's going to be really important information for you to know going forward, so that you can try to figure out how to do this from a business perspective. And it's just good information to know, like where you are, you know, sustainability wise. Okay. I know we're a little bit early. I really sort of, usually my chat blows up at the billing stuff and at some of the treatment choices. And so folks may have had a little bit of a foundation. But I also don't want to, you know, take time out of people's days if you don't have any questions or discussion.
I'm sure we'll have a lot more questions during the billing section.
Yeah, and I also think the tools, the next one where we're really talking about the tools, I really encourage all the care managers and their supervisors, because it's a completely different way to think about using and incorporating the tools. And most of the time without training, care managers just do them perfunctory, or they just ask the questions and then go about, you know, having a contact with the patient. And so really going through it is incredibly helpful. So Caitlin can put in the dates for the upcoming webinars. She pinned me down and we have that solidified. So we are all good there. So Caitlin, I don't know if you want to put the survey in.
Are you at the end? I don't want to.
Yeah, yeah.
Okay. Okay.
If people don't have any more questions, we may give people 25 minutes back in their day.
Well, they're really, really gonna like you now. I mean,
I know. Yeah. Usually, I mean, I love all the discussions and questions. Next time I built in probably a little bit too much time here for discussion. So, sorry about that. But if people feel like they didn't get questions answered, I'm glad to do that now.
No, we appreciate that. And you know, Verna, it's kind of like we're drinking out of a fire hose, right? And you're giving us all of this information. And I'm sure as we go back and digest it and review, we're just gonna continue to have questions in. So that is an important point. You know, I want to remind everyone this is a 5-year grant, and we are about 2/3 of the way through year 1. So really, over the next month or so, as you all are looking at how am I implementing this, I'm developing my registry, I'm building my registry. I know we have someone embarking on that, or I'm reaching out and I'm using the Ames tracker. I'm training my team. Does my team feel comfortable in using all of these different evidence-based models for coaching our patients, the billing piece, all of these different pieces? I'm sure. Please don't hesitate to shoot us those questions, and we'll get them ready. And if we can't answer something, we'll have those questions forwarded to Verna. So next time when she is here, we'll get those answered.
And we can just sort of start out with questions. So you're like, you know what, we talked about this medication support and I tried it, and, or whatever it happens to be. And so we can start with some questions that bubble up from maybe putting some of these things into practice.
Awesome.
Yeah, great. Well, thank you.
I am putting the survey into the chat now. If everyone could go ahead and complete that. It has just some basic questions about, the material. Did you understand the content? Do we have a better understanding of CoCM? And then there is a section on there that that asks if is there specific parts that you want to hear at the next training. You know, we do have an idea of what we want to go over for the next 2 trainings, but we're always happy to integrate some of these suggestions in there. So if it would be very helpful if you guys filled that out. And I know some people have had to come on and come off because they are handling work as well on top of this webinar. So I will make sure I send that out. I did take a picture of who's on the call right now, so I know who not to repeat send it to. As far as our next webinar, for June, I believe we agreed on June 18th. If that is news to anyone, please let me know. We have not decided on a time. I'm looking kind of for feedback here. Did this afternoon time work for most people? Or is there a morning preference? Or so I think we had a pretty good attendance today. Almost every person was on. So that's a little over a month. Scheduling wise should be doable. Okay, thanks, Julie. So that'll be June 18th. And then as far as July, there's 2 dates that we are considering, July 10th and July 24th. I did send those out in an email to the leadership for the organizations. And you guys are welcome to get back to me when you can on that. And we'll probably keep it afternoon if that just continues to be a better time for everyone. So. And also your responses on the survey are anonymous. So don't feel bad. Go ahead and put what you need to in there. And we'll get that figured out. Thank you, Julie, for July 10th. I think that's the consensus, but I think I got to get with Jackie, Dr. Jones, who is just spoiling me, by the way. She is so good, and she replies in like 2 minutes.
Oh yeah, she does. Yeah, she's pretty neat, pretty special.
Yeah, she takes good care of you.
She does.
But yeah, I'll get with her and make sure that 10th works for you guys too. And I will send out invites for those. And then lastly, just as I have you have a captive audience, I have been sending out the invites for the bi-weekly coaching calls. And if you haven't caught on to those yet, we'll do one individual during the month, and then we'll do a group with both Boston Mountain and Eastern Arkansas, so we can kind of have that peer cohort going. And I know there's a little bit of a difference in the cadence for the next 2 months just because there's some holidays coming up. Just be watching for the invite that I send for the end of July. That'll start us on the actual bi-weekly cadence. So I appreciate you guys being flexible. I know it's kind of messy sending out all these invites, but once I get that one sent out, that should be good. So.
Right. Okay.
Kim, I'm gonna hand it back over to you. I think I've covered all my housekeeping stuff.
Perfect. We want to thank you all for being on with us today and spending this afternoon. We also want to thank you, Verna. This is fantastic information, and you make it sound so easy and
Easy peasy.
That's right, easy peasy. Love it. In 90 days, we should all be
Up and running.
Up and running, absolutely. And then I just want to give a shout out to Misty Trent on our team. She is the project coordinator on this project with us, and it is her birthday today. So we want to celebrate you, Misty. We appreciate all you do to help us make this project run, and we want to celebrate you, and we hope you have a wonderful birthday and you get off this
We would have
call
sang
and
to you
celebrate.
had we known. We would have started that out. We could have done some behavioral activation around celebrating your birthday.
There you go.
Thank you very much.
Thank you.
I mean, what
Dr.
better way to spend it than with Verna's education?
That's right.
You can think of lots of better ways we should chat.
Well, all right.
No, it was great. Thank you.
We appreciate you, Misty. And thank you all for filling out the survey. We will see you for the next one in June and on the monthly coaching calls.
Thank you, everyone. It was a pleasure.
Good to see everyone.
Thank you.
Bye.
Goodbye.